attained with the specific efforts to reduce the maternal mortality rate. Prematurity, complications during birth, severe infections are some of the main causes of newborn death. The major causes of newborn death in India are prematurity 35% and neonatal infection 33%, intrapartum related complications and birth related asphyxia are 20%, and the congenital malformations are 9%. 75% of these newborn death can be prevented with known effective health measures provided at the birth and during the first week of life. Here, all the newborns must require essential newborn care to minimize the risk of illness and maximize their growth and development. Newborn Week is always celebrated with the aim to raise the awareness about the importance of newborn care for child survival and development, which includes importance of sanitation and how to keep the child warm and safe from pollution. The latest care programs announced by the government to be created awareness. So along with that, the most importantly, the awareness program wants to throw a light on the breastfeed to be with up to that 6 months, and every child must receive a skin to skin contact of mother and cot to be clamped earlier, and the family must be taught the importance of stem cell archival and drying the baby, monitoring the baby, and checking for the neonatal jaundice, and keeping the incubator assistance standby, and the following of the immunization chart and height, weight, head chart preparations, diameters, and the follow-up guidelines giving to the mothers. So there are lots of measures which is listed out under this awareness programs. Along with this, they need to have a clean rooms and sanitation facilities in every child care hospital, and maternity hospital is a major part of newborn care week agendas. With such campaigns, every mother can give birth and every parenting can have a healthy child. Also, to raise a national-wide awareness to prevent this neonatal death, Ministry of Health and Family Welfare, Government of India has created plenty of mother and child care programs over the years. The most prominent few are the Child Survival and Safe Motherhood Program 1992 and the Reproductive and Child Care Program Phase 1 and 2, National Rural Health Missions 2005, Reproductive, Maternal and Newborn and Child and Adolescent Health Framework 2013. These are all some of the framework which is created by the Government of India to create awareness among the public, the nationwide also. So always this newborn care week is taken with the keen interest of creating awareness and bringing the baby to the close circle of healthy environment. So I wish this day which is allotted by the pediatric department will help the students to carry some of the knowledge or the key points on this, which will help them to take care of their babies in their tenure of life. So I wish the program to be a successful one. Thank you all for having given this opportunity to me.
Thank you very much, ma'am. Now I hand over the session to Dr. Sudha P., Professor HOD, Department of Childhood Nursing, to introduce the guest speakers.
Good morning to one and all. Let me introduce the speaker of today's session, Dr. V. Sasi. Madam completed her graduation from Mother Teresa Institute of Health Sciences from Pondicherry University and post-graduation from Umayalachi College of Nursing from MJ University and a doctorate from Annamalai University. And she has started her career as a staff nurse and has held various positions in the field of nursing. And she is currently guiding PhD under BMRF. And she has organized many conferences and workshops and also faculty development programs. And she is a recipient of Outstanding Performance Award in BSc and AMM Arunachalam Silver Medal and Best Clinical Nurse in Post-Graduation, and also was awarded with Bharat Vidya Shiromani Award for Outstanding Achievements in Education by Indian Institute of Education and Management, and National Mahila Ratan Gold Medal Award by Indian Solidarity Council. Madam has published many papers in national and international journals and has received the Best Paper Award in the International Conference. And Madam is currently holding the position of Vice Principal from IQAC Coordinator in Vinayaga Missions College of Nursing. Ma'am, I welcome you, ma'am. And now the floor is yours.
Thank you, Sudha.
Ma'am, let me share the presentation.
Yes, please. Thank you for giving me an opportunity to present title regarding infant of diabetic mother. This condition is growing nowadays, and this is of an utmost importance, which is to when you give care to this particular group, we can prevent so many things, so many untoward effects in the infants that we will look into in this presentation. Next slide, please. Hello. Yes.
Yes, ma'am.
Yes. As an introduction, infants of diabetic mothers have experienced a nearly 30-fold decrease in morbidity and mortality rates since the development of specialized maternal, fetal, and neonatal care for women with diabetes and their offspring. Before then, the fetal and neonatal mortality rates were as high as 65%. We could not imagine now. But today, 3 to 10% of pregnancies are affected by abnormal glucose regulation and control. Of these, we could see 80 to 88% are related to abnormal glucose control of pregnancy or gestational diabetes mellitus. Next slide, please. So as the lifestyle changes, the incidence of diabetes, particularly gestational diabetes, has significantly increased in the last decades when compared to that of 1995 or 1978 statistics. The World Health Organization has predicted that between 1995 and 2025, there will be a 35% of increase in the worldwide prevalence of diabetes. So diabetes is going to be a leading cause. And Indian women have 11 times more risk of developing gestational diabetes mellitus as compared to women in other parts of the world. Next slide, please. Whereas in India, the prevalence of GDM, this is of results from the studies, it shows that it varies in different regions with a reported prevalence of 3.8% in Kashmir, 9.5% in Western India, and 6.2% in Mysore, and 22% in Tamil Nadu. In a recent study, the prevalence of gestational diabetes in South India was found to be 17.8% in urban women and 13.8% in semi-urban and 9.9% in rural women. So 3 to 10% of pregnancies, as we have seen these things in the previous slide. So 3 to 10% of pregnancies are complicated by abnormal glycemic control. Among this, 80% are caused by gestational diabetes mellitus. So it is a high time to think over and to prevent this particular condition so that we can save the newborns. Next slide. So this infants of diabetic mothers, they are prone to various neonatal adverse outcomes, particularly the metabolic and hematological disorders, the respiratory distress syndrome, cardiac anomalies and cardiac disorders, neurological impairment, mainly due to perinatal asphyxia and birth traumas, among others. Macrosomia is the most constant consequence of diabetes, and its severity is mainly influenced by maternal blood glucose level. Next slide, please. Next slide, please. Yes. So what is infants of diabetic mother? Any offspring of a gestational or insulin-dependent diabetic woman who may be of type 1 or type 2 dependent or just as a gestational or sometimes of an impaired glucose tolerance. The offsprings of these people are called to be as infants of diabetes mothers. Next. So what happens in this infant of diabetic mothers? Normally, the insulin, it does not cross the placental barrier. Whereas the maternal glucose level from the mother, if the mother is seems to be of a hyperglycemic state, right, that maternal glucose that crosses to that of a placenta, and it enters into the fetus. As it enters into the fetus islets of Langerhans cells, it goes into that of a hyperplasia, right? And it affects the beta cells, that's it. And this excessive, it makes that islets of Langerhans to secrete more of a insulin in utero. And that results in hyperinsulinemia in utero itself, which has an effect on various fetal organ system. The main effect is of anabolic effect. So what is this anabolic effect? So anabolism means, you know that very well, it is of building, right? So the body, it starts to synthesize the fat and accumulates the fat. It is not that of an edema. Because of that, the baby goes for the macrosomia. It is fully of accumulation of the fat tissues. So that because of this anabolic effect, the fetus goes to that of a macrosomic, and also some of the other organs, particularly with that of a heart and the liver, the size of a heart and the liver, that also it goes to that of a increased size. Whereas the size of brain and kidneys are not affected in this condition. That is the beauty over here. And this particular anabolic effect, it mainly takes place during the third trimester of a pregnancy. So this is the gist of a pathology behind the infant of a diabetic mother. Next slide, please. So with that effect, with that hormonal effect, it has not only with that of a fetus islets of Langerhans, it has its effect on the other systems also. That's what, no, previous slide. Previous slide. Previous slide, please. Yes, the same. So as we know that the maternal hyperglycemic state, when it is not controlled, the mother may show increased abortions or stillbirth, and sometimes goes into that of a renovascular disease, and fetal anomalies are so common with these mothers. This maternal diabetes, when it affects the fetus, that is a fetal hyperinsulinemia, that condition we have seen just now, and that results in the fetal cell hyperplasia, which results in macrosomia. So why macrosomia is so important? That causes that when the baby is big, it could not pass through that of a birth canal, which results in that of a birth trauma. And sometimes what happens means, it may not be of a simple peeling of the skin. Sometimes when you pull the baby out, it may cause a fracture to that of a clavicle, and also it results in that of a brachial plexus injury. And the macrosomia also results in that of a cardiac hypertrophy. And not only with that, the hyperinsulinemia has its effect on that of fat metabolism. It shows that increased fat metabolism, which results in that of relative hypoxemia. And that is the main reason for that of a polycythemia. And again, the polycythemia contributes for the development of a hyperbilirubinemia. On the other side, it affects the lung maturity. So how it affects the lung maturity? So because of this hypoxic insult, it causes the hypoxic insult as well as to that of increased insulin production. It results in the it affects the incorporation of a choline into that of a lecithin. We know that lecithin and the sphingomyelin ratio is very, very important for the surfactant production. So here lecithin is being incorporated with the choline. This particular choline component will not be incorporated in this particular level, that is a hyperinsulinemic conditions. So that results the decreased production of the surfactant. So which ultimately results in the condition called to be as a respiratory distress syndrome. And similarly, this hyperinsulinemia also affects the parathyroid maturation. It mainly decreases the parathyroid maturation. Because of that, the calcium and the magnesium imbalances may result. So this is the effect of diabetes, particularly of that is a hyperinsulinemic condition over the fetus. Next slide, please. Next slide, please. Yes. So we already seen some of the effect. This effect is nothing but the morbidities of the infants when their mother is of a diabetic. The same, that is a microsomia, hypoglycemia, RDS, IUGR, that is intrauterine growth retardation. This particularly occurs when the blood sugar level is not being controlled in the first trimester. When the first trimester sugar is not under control, definitely their offspring is going to have this IUGR. And hypocalcemia, hyperbilirubinemia, anomalies, polycythemia, hyperviscosity is mainly because of polycythemia. The hyperviscosity is a cardiomyopathy and increased fetal death and postnatal problems. Next slide, please. Yes. Now we'll see each aspect what to be looked out. Macrosomia. So when you say it is a macrosomic, because then the infant birth weight is more than 4 kgs and our head circumference and length is more than 90 percentile, then that particular baby seems to be a macrosomic. It's a huge baby or gigantic baby, we can say. So IDM have increased fat cells and also fat cell hypertrophy, and excess non-fatty tissue in shoulders and scapular areas could also be noticed in the macrosomic babies. Next slide, please. Mostly this macrosomic babies are seen among that is insulin dependent mothers, and excess growth happens in the third trimester. This also we have seen out, and gestation diabetes mothers have same incidence of macrosomic infants as that of other diabetic mothers. There is no difference in it. Next slide, please. Yes. What is this birth injuries? We have seen only brachial plexus injury and fractured clavicle. Apart from that, we have humerus fracture also, and facial nerve injuries could also be possible. And sometimes when the head has not been delivered and it has been in the, it got stuck out, right? Then there is a chances for that goes into that cephalhematoma formation. And shoulder dystocia, this is so common, 2 to 4 times it is more common. And this macrosomic baby, so as soon as the baby is being out from the mother, they will go into a hypoglycemic state. And there is an increased risk of asphyxia in these children and increased recurrence risk in the mother also. Next slide, please. Yes. So that's regarding a macrosomia. And comes to that of a congenital anomalies. Up to a 4-fold increase in infants of insulin-dependent diabetes mellitus or high risk for developing this congenital anomalies. The incidence, if you look into it, 6 to 9%, and these accounts for about 50% of mortality. So the malformation is shown to occur before 8 weeks of gestation. That is, that's what I said, that when the blood sugar level is not been controlled during the first trimester of a pregnancy, the organogenesis is getting affected. So that's it. The malformation is that occurs before 8 weeks of a gestation. The etiology is not so clear in this particular aspect. They states that is the theoretical things says that hyperglycemia can be one of the reason, and glucose can act as a teratogen here. So what are the defects we could expect in the cardiovascular system, particularly the VSD and transposition of great vessels, and in the skeletal system, especially we could see that of a caudal regression syndrome. So what is this caudal regression syndrome? This is nothing but the sacral agenesis. So this sacral agenesis, it varies in the degrees of development, and the developmental failure, it involves the legs, the lumbar region, sacral, coccygeal vertebrae. All these 4 vertebrae gets affected out, and corresponding segments of spinal cord will also be involved. And that results in that of a urinary incontinence and also dribbling. So that is of the caudal regression. We could not say that all the areas, that is a lumbar, sacral, all these 4 things needs to be involved. Any one or to that of extent. That according to that of the severity, it differs. When it comes to that of a CNS anomalies, meningomyelocele, anencephaly, and holoprosencephaly. This holoprosencephaly is so common, and even meningomyelocele could also be seen commonly in the when the mother has not been controlled with the proper blood sugar level. And others, you could see renal system is getting affected. Renal agenesis is common, and in the gastrointestinal system, that is of a small colon syndrome. There is a condition called to be as a small colon syndrome, where the size of the colon is very small, so that the absorption of the things it gets affected out. So these are some of the congenital anomalies we could expect when the baby is being affected with that of hyperinsulinemia. And the incidence gets decreased with the tight glucose control in the mothers, particularly to that of a first trimester of a pregnancy. Next slide, please. So next comes to that of a respiratory syndrome. This is so common because already we have seen that the lecithin sphingomyelin ratio is getting affected because of a hyperinsulinemia. That is the reason for the hyaline membrane disease resulting in respiratory distress syndrome. The increased risk of RDS in IDM is when the baby is less than 37 weeks of gestation, and possible insulin interference with surfactant composition and delayed maturation of surfactant system is seen over here. That's what is already discussed. And comes to that of a metabolic complication, hypoglycemia, hypocalcemia, and hypomagnesemia. All these three friends gets involved here. Next slide, please. Hypoglycemia, it occurs in up to 25% of infants with diabetic mothers. Half of the hypoglycemia occurs in first 24 hours. Yes, of course, when you cut down the, that is when you cut the relation between the mother and the baby, right? Because of a hormonal withdrawal, this hypoglycemic state suddenly occurs, and less likely when the mother's glucose is tightly controlled, and it may be often asymptomatic. We may not diagnose it immediately because you know very well that a hypoglycemic state could be withstood by the baby without any symptoms for about 3 days, right? So that is there. So because of that, many times we may miss the hypoglycemic state. Okay, next slide, please. Comes to that of a hypocalcemia and hypomagnesemia. It occurs in 17% or more of IDMs born to mothers who are insulin-dependent diabetic mothers. Usually 2 to 3 days after birth only, this hypocalcemic state is evident. And decreased parathormone or parathrin hormone secretion in IDMs is the main reason for this hypocalcemia state. And it have decreased calcium transfer because of this. And at the same time, we have decreased magnesium levels in the mother, which in turn, it affects the release of a parathormone in the babies. That is, it gets decreased in the decrease in the release of parathormone. Again, it complicates the hypocalcemic as well as a hypomagnesemic state. Next slide, please. So why polycythemia? So this is mainly associated with the poor glycemic control or maternal vascular disease. And we have seen that the baby's fetal lung is not so, because of the surfactant deficiency, lung has not been functioning out properly, and that results in that of the fetal hypoxic state. And this fetal hypoxia results in the high polycythemia, and polycythemia again contributes to hyperbilirubinemia. This already we have seen out, and this in turn affects the RBC production. So there is an ineffective RBC production, and it may further lowers the glucose level. So all these are linking pin, like if one is leading to that of another, again it leads to that of another, and the same it results to that other condition, that is a polycythemia. Next slide, please. So we have just seen what is the effect in detail, and we are now in the assessment. As a nurse, what and all we have to do, that's what we are going to see here. So first, before proceeding into assessing the baby or touching out the baby, is try to seek some information about the mother's diabetic state, whether what classification it is, whether of insulin dependent or type 2, it is gestational, what is the severity of the particular disease, and then you move on to that of a baby's condition. Okay, so after collecting out the information regarding classification and degree of severity, you just assess the APGAR score of the infant, and just see to that whether the APGAR score is good enough. That is, there is no distress in it. If at all the baby's APGAR score is below 7, we have to start with that of a resuscitation measures. And at the same time, look out the lab test also. Look out with that of hemoglobin level, hematocrit level, glucose level, calcium, and blood gases. And also look for that of the any fetal test, that is of fetal alpha fetal protein has been done previously in order to note the fetal lung maturity. And it is better to go for the C-peptide immunoreactivity test. It is mainly to measure the fetal beta cell activity. So all these are essential to determine what is the state of the state in the baby. And then move to that of a physical examination. That is the weight and the length of the baby need to be measured. And if you are seeing out if it goes above 90th percentile, then we can determine that it is of a macrosomic. So remember, in macrosomic baby, it is not because of an edema the baby becomes so fluffy. It is mainly because of the fat deposition and the fat synthesis and the deposition. Baby seems to be so puffy. The cheeks are full enough and so plump enough. And they may have abundant scalp hair. And they usually be in a hypotonic position with the legs flexed and abducted, and they won't move as like that of another normal babies, right? So they're just like lethargic, they lie down in the hypotonic position. They shows the poor sucking reflex, that is mainly due to hypotonia and immaturity. Next slide, please. So how to manage these type of babies? So in the delivery, and particularly in the delivery room, consider this particular mother as a high-risk mother. Both mother as well as the infant is going to be as of a high risk. Our approach needs to be in such a way that it should be in such a way that that is treating both the people as a high risk. So once the baby has been delivered, clamp the cord immediately to prevent the placenta transfusions. So usually we will wait for about 3 minutes. So no need to wait over here. Clamp immediately in order to prevent the placental transfusion of the hormones. And check out with an APGAR. Follow the basic step of a resuscitation for an infant if it is indicated. Next slide, please. Next slide. Yes. So in the post-delivery, what need to observe and evaluate? Already we have discussed out. Just look out, just see with based on the APGAR, just see out whether the baby has an asphyxia. If asphyxia, just initiate with the basic resuscitation and you shift the baby to NICU. Look out to the birth injuries, if any, whether it is of minimal bruising or to that of other fractures, clavicle fracture, or to that of a humerus fracture. Right? Birth injuries we have to look out. And fastly, you just go through with that of malformations. Any observable malformation is there, right? And then just with measure with that of a weight and the length, you are going to determine whether the baby is macrosomic, and just check out with the heel test and heel prick test, determine the glycemic state of the baby. And also with that asphyxia, we can we can just determine what is the respiratory distress out. Next slide, please. Yes. So how to manage? Main thing is of place the infant in an isolate. After if the baby is having a respiratory distress, you start with that of the asphyxia. You start with that of a resuscitation, right? And you proceed with the resuscitation steps. In that there is no change. Whereas if the baby is not having any asphyxia, the baby is quite normal. Then in that condition, you just place the infant in an isolate for the temperature regulation in order to prevent increase in heat loss. As you know that newborns normally have more body surface area. In this macrosomic babies, they have more and more body surface area. So more amount of heat might be lost. So prevent the heat loss, you just keep the baby in the isolate. If the isolate is not there, cover the baby or mummify the baby properly and keep it. Maintain adequate hydration state in an infant. by administering fluids if it is indicated, if it is ordered, in order to prevent the dehydration as well as the polycythemia. So what is a very important thing over here is better initiate the breastfeeding within 1 hour of a delivery, so that this will take care of a hydration state as well as that of other thing. And maintain an intake and output chart. This is very, very essential, because as you know that once the hormone transfusion has been cut out and the baby is being delivered out, right, the baby may urinate more, right, a hypoconcentric urine, it will come out more. That means that urine is not concentrated, they may urinate excessively, and that also results in that of a dehydration state. So because of that, you have to maintain the intake and output chart strictly. And calcium supplementation is indicated if the calcium level is dropped to 7 milligram per deciliter. Otherwise, it is not it's not necessary to supplement with that of a calcium. The management of hyperbilirubinemia, respiratory distress syndrome, and sepsis, it could be carried out as per the protocol. Next slide, please. The most important over here is the management of hypoglycemia. So mostly this hypoglycemic babies are asymptomatic. This is mainly they could withstand that particular state for about 72 hours. That is the main reason. And this hypoglycemia can occur within 30 minutes. So we should be very careful. And that may last for about 48 hours or more. So what is needed? Check the blood glucose as soon as possible after birth, and at regular intervals, particularly every 30 minutes, we have to check it for about 48 hours. So initiate the breastfeeding. This is very, very important. Initiate the breastfeeding within 1 hour of a delivery. If possible, within a half an hour, we have to initiate the breastfeeding. So early feeds, it will take care of the hypoglycemia also. It will treat out that also. Suppose if the blood glucose is falling below 30 milligram per deciliter in full-term babies, and below 20 milligram per deciliter in preterm babies, then we have to go for IV dextrose. As per the indication, the IV dextrose is given to the babies in the slow infusion rate. And in case in that particular condition it is not responding, then we can also try out with the crystalline glucagon. It can be given either subcutaneously, intramuscularly, or intravenously to an infant who has a good glycogen stores. If you see that a good glycogen stores is there in particular babies, you can try out with that of a crystalline glucagon. Even epinephrine can be given in order to inhibit the release of an insulin and stimulate the release of a glucose from the glycogen stores. Next slide, please. So what is the prognosis? The prognosis, it's 10 times more likely to be obese. So these, though we treat much in the delivery room and thereafter, the infant of diabetic mellitus mothers seems to be 10 times more likely to develop obese in the later period. And macrosomic infants are 6 times likely to be obese at the age of 7. An increased risk of teenage obesity is also possible, and also increased risk for glucose intolerance as young adults. So this is not that at one point that thing has got stopped out. It continues and it carries throughout the lifetime. That impact it continues. Then developmental problems are less likely in asymptomatic hypoglycemic infants. So please underline this asymptomatic hypoglycemic infants, whereas the symptomatic hypoglycemic infants, the developmental risks are there. Now, approximately 15 to 25% of infants of diabetic mothers die despite optimal care, because they won't follow the treatment properly. Next slide, please. What is the follow-up? What we need to do for these type of an infants is we have to assess the developmental risk as well as the metabolic risk. Under developmental risk, rule out for cerebral palsy and seizures if the mother's reports that 3 to 5 times or they have seizures attack, that is expected in this particular group. So please rule out for that also. And the small for gestational age infants, diabetes mellitus infants have increased risk for cognitive delay at 3 to 5 years. So the cognitive aspect need to be assessed till 5 years. And if possible, after that also we can assess it. And what about the metabolic risk? This infants of diabetic mellitus with the one parent type, with one parent, either of the parent is of type 2 diabetes mellitus, then they have 1 to 6% risk of diabetes mellitus themselves. They may soon develop the diabetic mellitus. So that is of metabolic risk. So it is better to follow this group of an infants throughout the lifetime, so that some of the risk could be reduced. Next slide, please. No, prevention. Yes. So what is needed? The preventive aspect is very, very important. See, always the prevention is better than cure. So in this gestational diabetes mellitus, so nothing has been, what to say, it has just occurred during the period of a gestation. Whereas in other diabetic mellitus mothers means they carry the disease before itself, that is before the time of a pregnancy. So whatever it might be, right, the glucose, the level of glucose could be maintained in their body if they attempt with that of some preventive measures. So what we have to do is you give a sufficient education regarding her disease. What is first you sensitize that group of mothers about their disease, and you tell about the importance of maintaining the euglycemic state throughout the period of gestation. This is very, very important. Due to health professionals resources lacking, and to that of time constraints, the people are not giving much importance towards educating the mothers in this particular aspect. This is very, very important. So we have to carry out this whenever we come across with the condition, mother with this particular condition. And monitor the infants throughout the childhood with the GTT, that is a glucose tolerance test, at least once in a year. So these type of infants need to be given GTT test at least once in a year to rule out the childhood diabetic state. And when the baby seems to be of obese, grow obese means, then you have to initiate measures to prevent the obesity in these children. So this is what some of the preventive measures that could be taken to prevent the effect of the diabetes in the infants and the carryover of the effect throughout their lifespan. So that's regarding the infants of diabetic mothers. Thank you. Any queries?
Thank you very much, ma'am. It was really a wonderful and informative session. I request the participants to put your queries on the chat box. At the end of the session, your queries will be clarified by the speakers. So the next session, we will start with nutritional needs of critically ill newborn. So before starting the session, I'll request Dr. Sudha B, Professor in HOD, Department of Child Health Nursing, to introduce the guest speaker.
Kindly, can you just stop sharing the screen?
Yes, ma'am.
Yes. So the next speaker of today's session is Mrs. Godey Nayagi, who is MSc Food Science and Nutrition and currently pursuing her PhD under Pondicherry University. And she has completed her book submission yet to waiting for Viva votes. And she has 9 years of teaching experience and 3 years of clinical experience in her field. Madam has presented papers in international and national conferences and has also published papers in journals. And she has won the Best Paper Award in national and state conference. Madam was awarded with the prestigious Indira Gandhi National NSS Award for the Best NSS Program Officer, and similarly from the state of Puducherry also. May I now request Mrs. Godey Nayagi to take over the session.
Good afternoon, everyone, and thank you, Sudha ma'am, for introducing me well. And I thank Department of Pediatric Nursing and College of Nursing for giving me an opportunity to speak in front of everyone. and let's get into the class. And my topic is about nutritional care about on critically ill units. I request the host to share the screen.
Yes, ma'am.
Yes,
Thank
ma'am.
Yeah, thank you. So my topic is about nutritional care for critically ill newborn. And the overview of this today's topic is on nutritional needs of the preterm babies and their parental. Next slide, you can go. And the parental and the enteral supports. Based on that, you'll be seeing about the requirements of protein, carbohydrate, fat. That's it. Next slide, please. Next. Next. Yeah. So we all know about the classification of neonates. So according to the birth weight, it is being classified as extremely low birth weight, very low birth weight, and low birth weight babies. So extremely low birth weight babies are under 1,000 grams, and very low birth weight babies comes under 1,500 grams, less than 1,500 grams, and low birth weight babies have around less than 2.5 grams, 2.5 kg of body weight. And they are also classified based on their small for gestational age. If the neonate is birth weight is around less than 10 percentile, which is further classified as symmetrical. Birth length and head circumference is less than 10 percentile, and asymmetrical when the birth weight and the head circumference is preserved at about 10th percentile. So, and the other classification is also based on appropriate for gestational age. So that is the birth weight of the neonate is between 10th percentile and the 19th percentile. And the last one is large for gestational age. So there the neonate birth weight is about 19th percentile. Next. So, so, so we have here we are going to focus on the preterm babies. So here the preterm babies miss many nutrients because they are missing their nutrients from the mother through their uh, through their main umbilical via umbilical nutritional missing are there. So here, how to attain these growth velocity? So growth velocity are expected to be 15 to 20 grams per kg per day for the infant who is weighing less than 1.5 kgs of weight. So if the preterm baby weight is about 1.8 kg, it has to have a growth velocity of 25 to 35 grams per day. And the length of the child has to be reached 0.8 to 1.5 centimeter per week, and the head circumference has to be attained 0.5 to 0.8 centimeter per week. So this is the expected growth velocity of preterm infant. Next. So why there is a decline in the growth velocity? So if the preterm baby have a protein insufficiency, malabsorption, low bicarbonates, anemia, low chloride, hyponatremia, micronutrient deficiencies, steroid use, and also increased theophylline levels when it has been induced for the apnea. So these are the causes. These are some of the causes which have an decline rate of growth velocity in the preterm babies. Next. Next slide, please. So how to achieve? So if there is a decline, what is the next plan for that? So we have to have a plan to increase the weight of the baby and how to achieve it or to how to deliver it. So by giving an appropriate nutrition, it will aid in improving the gut maturity of the preterm baby, and it will prevent anemia due to prematurity and osteopenia due to prematurity, and also to prevent necrotizing enterocolitis. So by appropriate nutrition, these can be achieved. So, and in which way we can deliver it? To mimic the intrauterine growth, there are two ways the child can receive the proper nutrition by enteral and parental support. Next. Next slide, please. So what are the guiding principles for an proper nutritional support? And the goal of neonatal nutrition is, when you have a proper goal, we can attain a postnatal growth, we can prevent the postnatal growth restriction, we can attain appropriate body composition, and also we can prevent neurocognitive development impairment. So, and also it will matches the intrauterine growth rate. So these are the guiding principles that we can achieve by the proper nutritional goal. Next, next slide. Yeah. So what is the rationale for proper nutrition? So here, when the child is in the intrauterine, here at the last trimester, here the child will receive an active amino acid transport. Here it is helpful for the bodybuilding, and they are involved in many other activities. The child will receive proper calcium, phosphorus, magnesium, and all these are involved in bone formation, and bone mineralization will happen. Rapid reactions will happen at the last trimester, and lipid transfer will be present, so especially the DHA, docosahexaene pentaenoic acid, which is a essential fatty acid which is needed for the development of gray matter of the brain and the cognitive development. So these things are happens rapidly in the last trimester. But if the baby is born prematurely, what happens here? So delivery of premature infant leads to higher energy expenditure, and here the child will have inadequate protein, and inadequate energy intake will be there if the child is born prematurely, and that will end up in negative nitrogen balance. When the body is undergoing a negative nitrogen balance, there will be a loss of protein in the body. The protein which is essential for the body growth will be declined, so that will further expose a child for the risk. So, and the delivery of premature infant also leads in lipid and glucose exit in utero, and amino acid lower profile also will be existing, and the child may further suffer from many opportunistic infections. So here, so we need a proper nutrition to recover and to rescue the child from the and giving the extra uterine growth. Next. So you can here you can see the total parental nutrition bag. So that has been provided for the adult as well as for the child. But here the capacity of the parental nutrition bag for the child is 150 ml. So you can see the three compartments of total parental nutrition. So one for glucose, one for protein, and another for lipid. Because when each three of mingles together, there will be some interactions that will spoil the delivery of nutrients. So there are different compartments for the delivery of different nutrients. Next slide, please. So the major concern towards the energy of preterm infant is to be calculated. Why? Because we have to be aware of increased energy expenditure in preterm babies, because they have low energy reserves, especially because they don't have a liver glycogen store, muscle glycogen store, and as well as they have less body fat. So in terms to uh, restore and all these things, we should have in mind to have a increased energy expenditure, and we have to know about all those things. When this combined with thin skin, when the preterm child is having a thin skin and less of energy stores, so we have to be very careful in calculating those energy requirements. So calculating energy requirements for preterm infants can estimated by uh, can be estimated to achieve a optimum growth. So here you can see the energy expenditure. So resting metabolic rate accounts for 40 to 60 kilocalories, and the activity of the child will determine will give an expenditure of 0 to 5 kilocalories, and the thermal regulations have a expenditure of 0 to 5 kilocalories, and the synthesis, protein synthesis, and hormone synthesis, many things will happen. So that accounts for 15 kilocalories of expenditure, and the stored energy expenditure also occurs. It accounts for 20 to 30 kilocalories. So totally, the total energy requirement of a newborn, especially a newborn, it is 90 to 20 kilocalories per kg per day. So this is the total energy requirement of a newborn child. But in terms of preterm infant, the energy expenditure exceeds about 110 to 130 kilocalories per day. And why? Because already they have less amount of energy stores, so they need to have extra calorie requirement. And that in terms of term infant, they require around 100 to 120 kilocalories. How do they get energy from um, the different sources of food, especially the carbohydrate, protein, and fat? So these are the three main compounds we get energies. So especially when we are talking about carbohydrate in terms of parenteral nutrition, so we'll be giving a glucose. Will be glucose. From that, we'll get 3.4 kilocalories of energy per gram. In terms of protein, we'll be getting 4 kilocalories of energy per gram, and in terms of fat, we'll get 9 kilocalories per gram. Next slide, please. So we have seen about the energy requirements, and now we'll see on about protein requirements. So premature infants will lose about 1% of protein stores daily when they are fed only on glucose through intravenous fluid to meet the metabolic needs. If the child does not receive protein or fat in adequate amount, that will end up in negative nitrogen balance. So that will automatically leads to loss of muscle mass. Muscle wasting will be there for the preterm baby and the sick baby also. So we have to focus on all the aspects like energy, protein, fat. So in terms of preterm infant, how we have to start? So we have to start with 2 gram of protein per kg per day for normal preterm baby, and very low weight baby and low birth weight baby accounts for 3.5 to 4 grams per kg per day of protein requirement. The late preterm baby requires around 3 to 3.5 grams per kg per day. For the term baby, we can start with the total parenteral nutrition around 2 grams per kg per day. And also, we can achieve at the rate of 3 grams per kg per day. Yes. Uh, so, what is the relationship between protein and growth? So, protein determines the negative nitrogen balance, balance of your body. So, whether it is positive or negative, that will be influenced by the nutritional protein status. So, the direct correlation between the protein. So, when we are giving a protein of amount 1 gram per kg of kg per day. So here the nitrogen balance, neither the positive nor the negative will be there. So we can decrease the weight loss of preterm infant by 5 grams per kg per day. So by including that, so 1 gram per kg per day endogenous protein by accompanying 4 grams of intracellular fluid. By this, we can reduce the weight loss of the preterm baby by giving 1 gram of protein per kg per day. But when we are giving about 3 grams per kg per day, the nitrogen balance, you can see here, it will be a positive nitrogen balance. Here the uterine rate can be matched with the within the first week of the newborn. So when we are giving the 3 grams of protein per kg per day, automatically we can attain a positive nitrogen balance that will exactly match the intrauterine rate, growth rate. So by delaying and decreasing the early weight loss of the preterm baby. Next slide, please. The protein dose in stock of total parenteral nutrition. So when we are talking about the total parenteral nutrition, especially the protein in terms of we are taking amino acid only. So direct absorptions. So we are not going to take in a complex. The child will not be getting a complex one. So it will be in a simplified and the digested form will be delivered through the parenteral nutrition. So which are readily absorbed. So in terms of protein, we'll be delivering only the amino acids. So amino acid stocks are available at the percentage of 2%, 4%, and 5%. And we are administering at the rate of 60 ml and also 80 ml per kg per day. So it has been shown that 4% of infusion shows the optimal growth requirement, and it also attain growth in the preterm baby. So for 4% of amino acid is being considered as an optimum dose of protein in stock of total parenteral nutrition. Next. So we have seen about protein now, and now we'll see about the carbohydrate requirements. So carbohydrate, so we all know about carbohydrate is a main source of energy for everyone. And here, in terms of preterm infant, lactose is a main form of energy, main form of carbohydrate. From there, it will receive the energy. So here, the main source of energy for infants is up to calculated for 50% from carbohydrate. In infants, carbohydrate makes maternal and and the milk which is and in human milk, the lactose is the main form of energy, as I told earlier. But in terms of formula feed, when we are talking about formula feed, it contains glucose polymerase, okay, and which is a predominant one. From the human milk, we have lactose. In the formula feeds, we have glucose polymerase, okay, polymers. So in preterm, infants lack the enzyme called lactase. So lactase is an enzyme which is needed for the uh, metabolism of lactose into glucose. So here in preterm, the enzyme activity of lactase is insufficient. But when the polymer forms of glucose is been given, in body we have alpha glucosidase. It will automatically digest the glucose, and it will helps in the production of energy. So, and in preterm infants, this alpha glucosidase is higher, as shown higher activity than the enzyme lactase. And here, the glucose infusion rate, we have to be concentrating on glucose infusion rate, how much we have to give. So we can see the formula that percentage of dextrose into IV rate by the 6 times into weight of the preterm infant. So while we are calculating these glucose infusion rate, automatically we can achieve at the rate of 5.55 milligram per kg per minute of glucose infusion rate. So this is a initial GIR rate. For preterm infant, we have to achieve around 11 to 12 milligram per kg per minute. For the term baby, we can gradually attain this GIR goal around 12 to 14. Next. So one of the most important requirement is lipid. Even though we get all those protein and carbohydrate, lipid also plays a major role because they provide dense source of energy that provides essential fatty acids also. Especially the essential fatty acids are called as linoleic acid, linolenic acid, which cannot be endogenously synthesized, but we have to provide it by the exogenous way only. So, and when we are not providing lipids at an adequate quantity, so they will develop deficiencies of essential fatty acid within 74 hours after birth when we are not giving a sufficient lipids. So what to do for that? So we have to introduce at least 0.25 to 0.5 or 0.5 to 1 gram of lipid per kg of body weight to avoid this essential fatty acid deficiencies. So especially the human milk contain total fat content. So it depends upon the diet and as well as the postnatal age of the mother. Okay. So if the mother after within 3 days of lactation, she will be having only 2 grams per deciliter of fat. But in mature milk, what happens? The fat content will be increasing up to 4 to 5 grams per deciliter. Next. Next slide. Yeah. So in terms of parental lipids, so we have to start with for the infants at the rate of 1 gram per kg per day. And we can advance up to 3 grams from 1, 2, and 3. But we have when we are retaining 3 grams of lipids by intralipids, we have to check for the triglyceride levels when we are achieving at the goal. Why? Because when the triglyceride levels end up higher, it may ends up with cholestasis also. So, and when we are attaining a cholestasis, we have to reduce our lipid up to 2 or 1, depending upon the response of the preterm child. So, parental lipid choices. So, there are 3 main parental lipid choices like intralipids, SMOF, and omega win. These 3 are the main thing which has been added for the supplementation of lipids to the preterm babies. So one for the first and foremost one is intralipid, that is 100% of soy oil from soybean. So this oil has been manufactured and it contains when we are adding 20% of emulsion, it gives 20 kilocalories per sorry, 2 kilocalories per ml of emulsion. Okay. But here there are some contraindications with the intralipids. But majorly, many of the people are choosing in many clinical setups, they are using SMOF. So SMOF is especially a different fatty oils plus different concentrations at different concentrations to decrease the activation of inflammatory indicators, which leads to decrease total parenteral nutritional cholestasis and liver failure in regular TPN solutions. So when you are giving an intralipid, especially only you are giving a soy oil, means what happens? The inflammatory responses will be higher because it is rich is only omega-6 fatty acid. But in SMOF, it is a combination of omega-3 and omega-6. Okay, so omega-3 and omega-6 combination will reduce the inflammatory response of the preterm infant, and automatically we can achieve the growth rate of the premature infant. So when we can recommend this SMOF is when the childbirth is less than 1 kg, or the child is having a GI disorder, as well as it can be recommended for the preterm infant when the intralipids is more than 2 weeks has been administered, or for prolonged need for parenteral nutrition. And when there is an intolerance of intralipid, as I told earlier, so when you are giving a 3 grams of lipid per kg per day, we have to check the triglyceride levels. When the triglyceride levels are higher, it may end up in total parenteral cholestasis. Okay, in that we can recommend the preterm child with the SMOF oil. That is soil. In that SMOF, it contains soy oil of 30%, medium chain triglycerides oil that is 30 percentage that we can get from coconut oil, from that always belongs to olive oil that corresponds to 25%, and fish oil corresponds to 15%. So when we are giving SMOF at the rate of 20% of emulsion, it provides 2 calories per ml. And the Omega Win, so it's a brand from Kabivin, Kabifresin. So in that we have 100% of fish oil. It contains 100% of fish oil, and it provides 1 calories per ml of lipid. Next slide. So we have seen all those things, and especially we have to focus on electrolytes also. So they also play a vital role. Here is so there is a difference between the preterm and the term infants. So sodium, potassium, calcium, phosphorus, and magnesiums. So they require sodium requirement is around 2 to 3 milliequivalent per kg per body weight. So here the potassium is not administered in principle within the first. Okay, so these are the requirement of electrolytes as well as. Next slide. So we also need trace elements for the premature infants. So we need zinc at the rate of, if the term baby is there, by total parenteral nutrition, we have to provide 250 micrograms. In preterm, they require 400 micrograms. So copper, they require 20 micrograms, and selenium, it is 2 micrograms. Manganese, it is 1 microgram, and molybdenum is 0.25 microgram, and iodide is 1 microgram. Next slide. Yeah. So what are the strategies to improve the outcome? So we have planning all those things, requirement we have seen, but we have to focus on the outcome also. Whatever we give to the child, depending upon the outcome only, we can decide whether the child is attaining a proper nutrition or not. Without a proper outcome, we cannot achieve anything. So to have a we have to have an aggressive parenteral nutrition. So by providing a 3 to 3.5 grams of protein per kg per day, and 0 to 0.5 to 1 also of per kg lipids per day, and also dextrose is required based on the clinical needs, and also the based on the premature requirement. And we have to begin as soon as possible to achieve the vascular when the vascular access is achieved, as well as we need calcium gluconate in infants if they are less than 1800 grams to for the bone mineralization process. Next. So now we'll focus on the enteral nutrition. So before going to enteral nutrition, we have to discuss about the benefits of maternal breast milk and the donor breast milk, whether to choose a formula feed or the breast milk. So it depends upon the mother, it depends upon the child as well as. So, so first, let's look on the advantage of maternal breast milk. So if you see about, we all know about the advantages and disadvantages of all those things. So just I'm giving a glimpse about it. So if you talk about the maternal breast milk, so it has a many advantage. Why? Because it is a whey dominant milk. So it has whey protein than the casein. So if you see the ratio of whey and casein, so whey is a highest percentage of 60 percentage and the casein is 40 percentage. Whey is easily digested than the casein, and it also the breast milk contains enzymes and it also aids in digestion. So it has numerous antibodies, immunoglobulins, and it also contains prebiotic, probiotics, and it also reduces risk of necrotizing uh, endocolitis, and also it is a cost efficient milk. So no need to spend any money on that. So that's a major advantage of maternal breast milk. And the disadvantage is it has low protein content if the mother is delivering a preterm baby. The preterm milk also having a low protein content, and it also has a low vitamin D and mineral content. And the stress also leads to decreased production of milk. So this is a disadvantage of maternal breast milk. Next slide, please. So next, the advantage between the breast milk and the donor milk. So breast milk advantage of donor milk, it is also easy to digest, and it also reduces the risk of necrotizing and endocolitis. And the disadvantage of the donor milk is it is also costly. We are borrowing from other person donors, and we are pasteurizing. So during pasteurization, there will be a decreased nutrients will be available that may also have an impact on the growth of the preterm baby. So and the antibodies and the immunoglobulins of the breast milk from the donor also have depleted amount of immunoglobulins and lipoproteins, and also have decreased lactoferrin and lysozyme concentration, and some lipases and lipoproteins also destroyed when it is goes for the pasteurization also, and it has been stored for a prolonged period of time. So what is the criteria to be given consideration for the donor milk to be given? So when the birth weight of the child is less than 1500 grams, and if the mother is unable to feed the child, and we should start it immediately, weaning the child at the age at the week of about 30 to 34 weeks with the corrected gestational age. Next slide, please. Yeah, what is the indication for enteral feeding? So feeding should be initiated at as early as possible for those with normal gestational tract and stable hemodynamics. So feeding should be initiated within 12 hours after birth for those with a birth weight of more than 1,000 grams, and feeding could be delayed until 24 to 48 hours after birth for those with less than 1,000 grams. Next slide. So the one of the enteral feeding is tropic feeding. So here the tropic feeding has, when we are talking about the tropic feed, it is hypocaloric, low volume, which is hypocaloric, low volume food, which helps to promote intestinal maturation in preterm infants, but they are less in calories. So we can give it for especially for the gut priming, and we can start at the rate of 10 to 20 ml per kg per day, and preferably with human milk, donor milk, or the express breast milk of the mother. So we can continue for 1 to 3 days and monitor for feeding intolerance. So we cannot continue more than 3 days because it is hypocaloric. So we cannot attain that calorie requirement for every day. So we can continue only for 1 or 3 days. And the advanced feeding, we can continue about 20 ml per kg per day until the goal volume is achieved. So what is the consideration in tropic feeding is it should be initiated along with the liquid protein if necessary when feed reaches 80 to 100 ml per kg per day in volume. And also you have to discontinue lipids when feed reaches around 80 to 100 ml per kg per day in volume. That is about trophic feeding. Next. The feeding plan for preterm infants. So you can see the table column here. So according to the birth weight of the preterm child and the child, so you can start at the initial rate of 10 ml per kg per day, and the volume at 15 ml per kg per day, and the feeding volume around 150 ml per kg per day. Okay, so some units begin at the rate of 1 ml every 12 hours and progress gradually to every 2 to 3 hours. The next slide. So there are many formula feeds. The best one is the best internal feed is mother's milk. If the mother's milk is not available, we can get from the donor's milk. If both is not available, we can focus on formula feeds. And as well as I want to give a point on it, when the mother is having a preterm delivery, the mother is also having a preterm milk that will not be sufficient enough for the growth of a premature infant. So to add upon it, the premature milk can be fortified with the fortifiers like human milk fortifier and other formula feeds to increase its nutritive value and also to enhance the growth rate of premature infants. So the other formula options which has been listed here, first we can see about the human milk fortifier. So it has been added to human milk to meet the needs of premature infants, and especially this human milk fortifier is designed for the infants is less than 34 weeks and less than 2 kg of body weight, and it has multi-nutrient supplement also. And there is other formula called preterm infant formula, which is designed especially to meet the nutrient needs of premature infants by providing higher amount of protein, calcium, and phosphorus. The calcium and phosphorus is especially needed to prevent the bone diseases like protein demineralization and protein development. So preterm infant formula mainly focuses on calcium and phosphorus also. And the translational formula, which is also available in the market. So it is needed for the continued feeding of premature infants at discharge and also until 9 months corrected gestational age. And it has a nutrient density between preterm and the most standard milk protein based formulas. The density of this translational formula has a higher density uh, around the standard milk protein. And the next formula is standard term formula, which is especially designed for infants and birth up to 1 year. And then and the fifth one is hydrolyzed formulas. So it is for the infants sensitive to inactive protein found in milk and soy-based formulas. The hydrolyzed protein formulas are easily digested that can be administered for the preterm infant, which has intact sensitivity to the casein and the soy-based formulas. And the last one is elemental formulas. So elemental formulas has especially based on amino acids for infants with severe allergy to intact protein, malabsorption, or GI impairment. So these are the formulas which has been available in the market. So we have to choose the formulas based on the requirement of the preterm baby and the body condition of the preterm baby. Next. So we came to the end of the session, and here we have a note that we have to save the newborn with proper nutritional care, even though we have other supportive cares also, but the nutrition plays a vital role in the lifespan of premature infant. Thank you. Do you have any questions?
Thank you very much, ma'am. It was really a wonderful session. I'm requesting the participant to put your queries in the chat box. So Thank you very much to all the speakers. And now we have came to the end of the session. So it's now time for the vote of thanks. I take it a great honor and privilege to propose the vote of thanks in this newborn week celebration. I express my sincere thanks to our speaker, Dr. Sasi, a Vice Principal cum IQSC Coordinator, Vinayaga Mission College of Nursing, Puducherry, and I also express my heartfelt thanks to Mrs. Kodinayagi, Lecturer cum Chief Dietitian, Vinayaga Mission College of Nursing, Puducherry. And I thank our well-wisher Principal, Dr. Muthamar Chelvi, and Vice Principal, and all department HODs and professors, assistant professors, lecturers, tutors, and delegates also. And once again, I thank you all. And I'm requesting all the participants to join with us for the continuation of the session by tomorrow's at the same time. Thank you all. The feedback link will be given at the end of tomorrow's session. Thank you all for your kind participation. Thank you.
Thank you all and all. We expect the participants to be present for the tomorrow's session also. Thank you all and all.